Welcome to our webinar entitled Informed Consent and Capacity Assessments for Patient-Centered Care. We're going to take a deep dive into these two topics, these two concepts. So what truly is informed consent and what is involved in doing a capacity assessment for my patient? Those are the questions you want to know. And we are here to talk about these topics with two experts. I would like to introduce our panel. So Charmin Robertson is a psychiatrist with 18 years of experience, working with both youth and adults in both outpatient and inpatient tertiary mental health settings. She's been a medical legal physician advisor here with us at the CMPA since 2018, and we are thrilled to have her here to discuss this topic. Welcome, Charmin.
I'm really pleased to be joining everybody today. Thanks.
And Mandy Lawson is a partner in Gowling WLG's Ottawa office. She practices primarily health law and medical defense, including as counsel to the CMPA. And Mandy is here today to share a wealth of medical legal knowledge on the topic of consent and capacity. Welcome, Mandy.
Thanks, Lisa. I'm happy to be here.
We also have Elizabeth Boileau, who will join us later in the webinar for our Q&A period, and she will be our moderator. And Elizabeth is an emergency physician and currently is one of our physician advisors in Safe Medical Care Learning at the CMPA, and so we will welcome her soon. And my name is Lisa Thurger. I'm an emergency physician and a medical toxicologist. And I am currently a physician advisor in Safe Medical Care Learning at the CMPA. I am very much looking forward to facilitating and hosting this discussion today. I will let you know that this session is being recorded. The Q&A is also being recorded, but the questions will be completely anonymous and posed anonymous. But I do need to let you know that we are recording this session. Now, as a panel, we have no conflicts of interest to disclose, except that both Charmin and I are paid employees of the CMPA, and Mandy is retained counsel for the CMPA. Before we begin, I would like to acknowledge the land that we are presenting from today. So the CMPA offices located in Ottawa are on the unceded, unsurrendered territory of the Anishinaabe Algonquin Nation, whose presence here reaches back to time immemorial. Now, we have more snow on the ground than you'll see in this photo, but this photo is actually of the land directly across from the CMPA offices and was taken by a CMPA member. Just picture it with a lot more snow on it today. I also want to recognize, though, that all of our participants are learning from many different areas across Canada, and I would like to honor and pay respect to these lands that you are on, and to all First Nations, Inuit, and Métis people throughout Turtle Island. Okay, so these are our objectives for today that you see. We're going to be discussing the essential elements, basically, of consent. We're going to talk about special considerations when you are obtaining consent and best practices for documenting this very important consent discussion. And then we'll move on to capacity assessments and dive into some of these things that make them so complicated, as I'm sure you can all agree, including a discussion about consent and capacity boards. All right, let's dive in and talk about informed consent. So informed consent, I think you would all agree, is an ethical and a legal requirement. And it essentially ensures that patients' freedom to agree to undergo a given procedure or treatment actually happens. And navigating the complexities of capacity assessments and obtaining consent is a critical aspect of medical practice. So physicians, essentially all of you on this webinar today, you play a very important role in helping patients understand both the diagnosis and the available treatment options. And often things like patient safety, patient autonomy, and medical legal risk are involved when managing these sensitive and complicated issues. So we're here to talk about these things and to provide some medical legal and some patient safety tips on the topic of consent and capacity. Okay, let's start with talking about the basic principles of consent. So Sharman, let's remind our members about the basic principles just to get our brains warmed up a little bit.
Sure, for sure. Thanks, Lisa. So when we obtain consent as physicians, we have to respect autonomy and personal dignity. And we cannot proceed with any investigation or treatment without valid consent. And if adequate consent isn't obtained, a physician may actually be at risk of being accused of negligence or in Quebec, civil liability. So when no consent is given at all, or when treatment deviates significantly from that for which the consent was given, a physician may be liable for assault and battery or failing to obtain consent in Quebec.
Okay. But I'm going to say the emerge doc in me needs to jump in here, Sharman, with an important exception to this. And that's when a physician has a duty to provide emergency care, right? When there is an imminent threat to life or health or where there is severe suffering. So what happens then, Sharman, when it's an emergency situation or when a patient or even a substitute decision maker is not able to provide consent?
Yeah, so let's talk about an emergency case example. So I'm sure we can all imagine cases, but let's take the example of a 35-year-old motorcyclist who's traveling alone in a small northern BC community. So they're in a motor vehicle collision and they present to the local ER with a pulseless, pale left arm and with a loss of consciousness and a blown pupil. And this person clearly needs to be transported out for care, but there's no substitute decision maker present. So in this situation, any treatment that's limited to saving their life or a limb or reducing any kind of suffering can be provided until consent could be obtained. And so it can't, however, be a question of preference or convenience for the emergency room physician. There must be an undoubted necessity to proceed. So because there isn't a substitute decision maker immediately available and this care has to be provided without consent, documentation is hugely important. It has to be contemporaneous and explain the circumstances why the physician felt that the treatment should proceed without consent. If they feel that might later be questioned, it's wise to get a second opinion and document that as well. And also attempts to contact the substitute decision maker should be documented. And of course, if you can get that consent to provide the non-urgent care, then the risk is certainly lowered.
Okay, that's a great example. Thank you for that, Sharman. And it's also a good reminder about documentation because this is key, and we'll dive into that a little bit more later. So now, what if the patient doesn't consent? What if the patient refuses treatment, Mandy? Can you tell us a little bit about that?
Yeah, that's a great question, Lisa. Consistent with patient autonomy, our courts have reaffirmed repeatedly a patient's right to refuse treatment, even when necessary to preserve the patient's life or health, and even when it's not in their best interests. Similarly, patients can withdraw consent at any time, even after they've signed a consent form or even undergone some of the treatment.
So do the courts support this?
Yeah, they do. And there's an older Ontario case called Millett and Schumann that's still relied upon in more recent cases, where a doctor administered blood transfusions to an unconscious adult Jehovah Witness patient who carried a card prohibiting blood transfusions. The physician felt the blood transfusions were necessary to save the patient's life. However, the court held that the physician should have respected the wishes of the patient, which were confirmed by family members who were in attendance at the time of the event. So, even though the treatment ultimately saved the patient's life in this case, the court found that the administration of blood transfusions constituted a battery on the patient and awarded damages for the mental distress and anguish that the patient suffered after learning that they had received these blood transfusions.
I think I know what you're going to tell me, but can the physician try to persuade the patient to get them to consent?
No, I think the answer is no. That's not appropriate. Physicians must explain the consequences of the refusal, but not create a perception of coercion at all. Reasonable alternatives also need to be explained to the patient and offered to them. And it's also important to remember that refusal of the recommended treatment does not necessarily constitute refusal for any treatment. So a physician would want to revisit the issue with the patient at a later time. And finally, as we've already said, documentation of the discussion, the informed refusal discussion in this case, is essential.
Great tip for documentation. Thanks, Mandy. Okay, so we've talked about the basic principles of consent and that patients have the right to refuse consent. Now let's talk about types of consent. So, Charmin, consent to treatment may be either implied or it may be specifically expressed either orally or in writing. Is that right?
Yeah, that's correct. And it's the clinical situation that determines which is the best approach. And so a lot of the work that we do reasonably relies on implied consent. And this can be evident in, the context in which a person presents. So if they're presenting to a clinic or to an ER, it's also evident in the person's behavior and words. So I guess whenever a physician is interacting with a patient, they should consider whether their actions imply permission for the examinations or investigations or treatments being proposed. And when there's doubt, it's really preferable for the physician to obtain express consent, either through, verbally asking for consent or getting it in writing. Express consent is particularly important when the intervention involves a sensitive examination or a painful procedure or an elevated amount of risk, or when it could result in alteration or harm of bodily function in some manner.
Right. Okay. And what needs to be present for consent to be valid, Mandy?
So there are 3 requirements that must be met. The consent must be voluntary, the patient must have the capacity to consent, and the patient must be properly informed.
Okay. So it's pretty self-explanatory, but tell us what you mean by consent being voluntary.
So what we mean by voluntary is that the patient's consent must not be forced or coerced. So as physicians, you'll want to be mindful of any pressures that patients may feel when considering treatment. For example, was it the patient's decision to consult with the physician, or was it that of a family member or friend or even an employer? And whenever clinically possible, patients should be provided time to consider their options after an appropriate discussion with their support system and the treatment team.
Okay, so that's the voluntary part. Now, can you briefly tell us about capacity? this part of it. We'll dive a little bit deeper into this later when we talk about capacity assessments, but tell us briefly about capacity.
Yeah, when it comes to capacity, what we mean is that patients are able to understand the nature of the proposed investigation or treatment and the anticipated outcome, and that they can appreciate the consequences of the proposed treatment or lack of treatment.
Interesting. One trick that I used to use when I was practicing emergency medicine to make sure that patients understood was asking them to repeat the information about the treatment or the procedure back to me in their own words. So I found that this was a good way to confirm that the patient comprehended or understood the situation. What do you think of that?
Yeah, I think that's a really good tip, Lisa. And sometimes having a family member of the patient or a friend or a translator, if that's appropriate, present during the discussion can also help with the understanding, of course, with a capable patient's consent for those persons to be there.
Okay. So let's wrap up the third element then that is necessary for consent, and that's ensuring that the patient is informed. Mandy, can you expand a little bit on that for our listeners?
Yeah, the informed piece requires providing patients with the necessary information so that they can make a properly informed decision. The consent discussion is actually a process where the patient and their physician discuss the diagnosis, recommended treatment, alternative treatment options, the material risks, anticipated benefits, and expected outcomes, and the consequences of not proceeding with the treatment. Patients should also be informed whether part or all of the treatment will be delegated to a trainee, since they have a right to know who will be involved in their care. And importantly, often signed consent will be obtained, but remember, a signed consent form is not a substitute for that consent discussion. Simply because the patient signed a consent form will not always lead to a conclusion that the informed requirement was satisfied.
Love that you said this, Mandy. This is so important for our members to hear. Informed consent is not just a signed sheet of paper. It's a process. It's a conversation about the risks and the benefits. And this is such an important message.
Yeah, that's right. It really is a process and not a sheet of paper. And I should also emphasize that when it comes to discussing material risks, we mean with material risks rather, which are defined as the side effects that occur frequently or that are serious enough to cause permanent disability or death. Our courts have stated that physicians should provide the information that a physician knows or should know that their patient requires to make a decision, what a reasonable patient would want to know. The discussion should be individualized and patient-focused, since different patients weigh the risks according to their own circumstances. For example, the discussion of the risk of a median nerve injury during carpal tunnel surgery would be more important to review with a concert pianist versus someone who does not rely on their fine motor skills to perform their profession.
Makes sense. Mm-hmm.
So it can be helpful to ask the patient what is important to them to help them explore their expectations and discuss their fears and concerns.
Yeah, I like that. And thanks for that example. Okay, let's talk about delegation of consent. So tell us, Charmin, who can actually get the consent? Does it have to be the attending physician? Can the medical student get the consent? Can it be another healthcare professional? Who can get the consent?
Mm-hmm. Well, it is the responsibility of the most responsible physician for obtaining consent. However, they can delegate the duty to an individual who has the knowledge and experience to understand and answer questions about the proposed intervention, the associated risks, of course, and address any of the patient's concerns that are specific to their own unique context. So this delegate should have access to the most responsible physician if they run into any questions or concerns that they can't clarify or answer on their own. And I think another aspect to remember is that if consent is obtained by one physician and a second physician actually does the procedure at a later date, it's best for the second physician to revisit the issue of consent with the patient on the day of the procedure.
Okay, great tips. It can be delegated, but that delegate needs to have all the right information and understand it. So thanks for that, Sharman. And now, how would you suggest documenting the consent discussion, Sharman? It was mentioned that the signed consent form sheet is not enough. So what else would you suggest?
I'm glad we're talking about this because it is a real risk point for physicians later with legal actions or college complaints. So many physicians don't document consent well or at all. And if they do so, they fail to meet a reasonable standard. So as you mentioned, signed consent alone doesn't meet expected standards because it really doesn't show evidence that a consent discussion actually occurred. So the consent discussion must be documented in the patient's medical record. And I know physicians are also under the gun in terms of time. It can be concise, but it has to be specific enough to clearly demonstrate that a conversation took place to obtain the informed consent. And this really is a physician's best defense against allegations that informed consent was not obtained. So there is a helpful mnemonic called PAR-Q, and it is a good way of structuring that discussion in your documentation. And it stands for documentation of the procedure, alternatives, risks, and any questions that were asked and answered. So this documentation should also include the common and rare but serious risks known as the material risks, as well as the risks specific to the patient's own situation, any questions that were asked and answered, and any mention of handouts that the patient was given, that's helpful to put in there too. And where relevant, a comment on the patient's capacity to consent to the treatment would be noted.
So PAR-Q can not only help structure the conversation with the patient, but also when you document it. Thanks for that, Sharman. Okay, I promised that we were going to talk about special considerations in informed consent. So let's do that now. Now, special considerations include minor patients, patients with mental illness, and incapable patients who most likely will require substitute decision makers. So let's start with a case to help us understand these special considerations. So what if a 14-year-old female who is accompanied by her mother to the emergency department presents with, say, abdominal pain? The youth asks to speak with a physician privately, but the mother objects. Now, luckily, the physician does manage to see the patient without the mother present, and the patient tells the physician that she has been sexually active and is afraid that she's pregnant. The doctor discusses the need to then do a pelvic examination and to collect cervical cultures. The patient understands all of this and agrees to proceed, but asks that the physician not discuss this with her mom. So Sharman, what can a physician do in this situation? Can you talk to us about the capacity to consent as a minor?
Yes. So before proceeding, this emergency physician would want to consider this youth's capacity to consent to two things: the disclosure of their personal health information and their treatment. So the determinant for capacity to consent is maturity and not chronological age, of course, with the exception of Quebec, where youth under the age of 14 do require a substitute decision maker. A young person in the rest of the country is considered capable of consenting or refusing treatment if their cognitive and emotional development allows for a full understanding and appreciation of the nature and consequences of their decision. So the physician would want to determine and document this patient's capacity to consent to the sharing of their health information with their mother and to her treatment. So if this patient is found to be a mature minor, i.e. capable of consenting, she has to provide consent to involve her mother in the medical encounter or the decision-making process. So depending on the nature of the particular medical condition or the complexity of any proposed treatment, it's still often prudent to stress to the mature minor the importance of involving their parents and obtaining permission to do so. And if this patient is actually not capable of consenting, her mother would be the one to provide consent and would do so sort of in the best interest of the youth.
That makes sense. Thanks for that, Sharman. Can you now tell us about special considerations for patients experiencing mental illness? So what should a physician consider when working with a patient with a mental illness?
Well, I think it's similar to other individuals who have general medical conditions. We have to assume that the patient is capable of consenting to treatment unless they have a reason to suspect otherwise. And at that point, they would assess and document the person's capacity to consent to treatment. So many individuals with mental illness, including those who are admitted to a psychiatric facility or hospital, continue to be capable of controlling or directing their own medical care, including the right to consent or refuse to treat treatment. So remember, capacity is task specific, and a patient who is deemed incapable to consent to one thing, for example, their mental health treatment, may still have sufficient capacity to make other decisions, such as offering consent to other general medical treatment. So it's really important to consider and document the individual elements of capacity.
That is a great reminder. Thanks, Sharman. Now, for our third special situation, that is sort of that's incapable patients. So what happens when an adult patient is not capable of consenting, Mandy?
As a first step, physicians will want to confirm whether the patient has made an advance directive. Advance directives are sometimes referred to as living wills, and in some provinces, they are contained in powers of attorney for personal care. A directive is essentially a legal document through which a capable person gives another individual the authority in advance to make decisions on their behalf when they become incapable. The directives often include instructions that the appointee must follow when making decisions on behalf of the incapable person. However, if a patient doesn't have an advance directive, there is legislation in many provinces and territories that provide a means of obtaining consent, or rather substitute consent, when a patient is deemed incapable. And this legislation typically sets out a hierarchy or a prioritized list of individuals who are authorized to give or refuse consent on behalf of the patient.
Okay. So then what happens when substitute decision makers do not agree with physicians and the treating team of an incapable patient? Sharman, you've maybe even had some calls about this, have you?
Oh, for sure. Yeah. This can be pretty tricky. generally, the approach is to consider having a conversation with the family. And you want to find out what their concerns are about the diagnosis and the treatment, but also have a discussion about what the role of the substitute decision maker is, and that's to act in compliance with the patient's prior capable wishes. If that's not known, they would consider other factors such as the patient's known beliefs and their values, and also considering what is in their best interest according to the treatment team. And it really is trying to come to some kind of resolution, if at all possible. However, ultimately, if a physician believes that the decision maker isn't acting in the patient's best interest, the matter can be brought to the courts or the Office of the Public Guardian for direction in accepting treatment decisions. Ontario and the Yukon are unique provinces in that physicians can make an application to the Consent and Capacity Board. You know, there are so many variables in these scenarios that I would recommend that physicians contact the CNPA in these situations, and we can help you navigate the options.
Yeah, I think everyone here on this call would agree these are complex, so that's a great time to give the CNPA a call. Thanks for that, Sherman.
Mm-hmm.
Okay, I'd like to thank you both for this part of the discussion about consent. We're now going to move on to talk about capacity assessments.
Mm-hmm.
So, Sharman, what key things do you want our members to know about capacity assessments?
For sure. Well, back to basic principles, it's really important that a physician respects patient autonomy and doesn't necessarily limit a capable person's right to consent to or refuse treatment. Like I said before, we have to assume that a person is capable unless we have reason to believe otherwise. And concerns about a person's capacity can come from our own observations, or collateral information from family members or friends or other members of the healthcare team. And if a physician has reason to question the capacity, an assessment would be conducted and documented on the chart. So like I mentioned, capacity is task specific, and we could be asked to comment on a person's capacity for many different things, including their ability to consent to treatment, to create a will, that would be their testamentary capacity, or to manage their finances, their financial capacity, or to disclose their personal health information, or to live in an assisted facility. So there are many elements. And again, reinforcing that fact that patients may be capable of some of these tasks and not others. So consider all areas and document these well.
Right, it is task specific. I think that's a great reminder. And also another good reminder to document. Thanks, Sharman.
Mm-hmm.
So now when a physician questions that a patient may not be capable of consenting to treatment, they must assess their capacity because it is, in fact, every physician's obligation to assess their own patient's capacity to consent to treatment when required. But for more complex clinical scenarios, this may require input from specialists like geriatrics or perhaps psychiatry. But ultimately, the responsibility lies in that of the attending physician. Is that right, Sherman?
Yes, it is their ultimate responsibility, even if they're not a psychiatrist or other specialist. But it is acceptable to use the input and consultation reports from specialists, as well as collateral information from family and friends. If a physician believes that a patient isn't capable or is unable or unwilling to provide that information themselves. And so all of that information can be used to help a physician develop a reasonable clinical decision about whether the patient is capable. And when we think about assessing capacity, we're interested in two separate tests. Does the patient meet both of these tests? And the first is that, does the patient understand their diagnosis and the nature and anticipated effects of the interventions and treatment options being considered? So understanding, the way I think about it is, can they remember, can they concentrate and focus and retain that information? And potentially, as you said, repeat it back. And that would sort of constitute understanding. The second piece would be, do they appreciate the consequences of accepting or refusing treatment? And this appreciation really has to do with whether an individual has the ability to take all of the facts that have been presented to them and apply it to their own personal circumstances.
Okay, so let's use an example then to apply these two tests. So say you have an 80-year-old patient on anticoagulants who perhaps has fallen and unfortunately struck their head. Their family brings them into the family physician's office for management of confusion and a headache. But the patient is refusing to then go to hospital or to have any imaging done. In fact, they're just requesting unproven therapies such as topical arnica to treat their headache. So what do you think of this, Charmin, and this particular patient's ability to consent?
Sure. This is a good example, actually. We can kind of do a partial assessment and talk about what a capacity might look like. So in this situation, because of the nature of the injury, a physician would have reason to question whether the person is capable of consenting to their treatment, particularly because they've refused to undergo further investigations or to go to the hospital. This may not make sense in this context. And this is following a blow to the head. So they would begin trying to discuss information related to the nature of the injury, the risks of anticoagulation, and the potential for an intracranial bleed, including disability or death, and the recommendation for further imaging and monitoring. And through that discussion, again, can they understand it? Can they repeat it back? Can they ask any clarifying questions related to the information that's provided to them? And that would help determine whether they met the understanding test. And if we consider the second test, so whether they are able to appreciate the impact of refusing further investigation and treatment, can they take the medical facts that were presented to them and apply it to their own circumstances? So the assessment of appreciation can be very nuanced. And so it's important, the higher the risk of delaying treatment or accepting treatment or refusing it, the more certain a physician must be in determining whether a person is capable of appreciating the consequences. And they really should be able to explain why this specific treatment isn't acceptable to them and why they're choosing to accept the risks. So in this case, it would be hard to argue that the test for appreciation was met if the patient simply says, you know what, I think I haven't had a bleed and I'm going to be fine. It would be hard to imagine that they've actually met that test of appreciation.
I know that makes a lot of sense. And thank you for using that example to show the members how to apply both tests when assessing capacity. That's great. Okay, so now, Charmin, what about capacity assessments for non-treatment purposes? You must receive calls about that as well?
Absolutely. Physicians are often asked to assess a patient's capacity for non-treatment purposes, like creating a personal directive or changing a will or a personal directive or managing their finances. And in these situations, there's always a risk, an elevated risk of either family conflict or legal involvement, whenever money is involved and managing finances involved. So it's just really important for me to reiterate the importance of documenting these capacity assessments thoroughly. And you want to document the purpose of the capacity assessment, so what element of capacity you're actually assessing, the date of the examination, and what the findings are.
Okay, that makes sense. And Mandy, do you have anything to add to that?
Yeah, I think it's probably helpful for members to know that many legal processes for appointing a guardian or personal representative or activating a power of attorney require applicants to submit a capacity assessment conducted by a physician or an affidavit from a physician attesting to the patient's incapacity. So in these situations, physicians are usually only asked to assess the patient's general capacity to understand information relevant to the particular decision and to appreciate the reasonably foreseeable consequences of the decision or failure to make the decision. Now, in some jurisdictions, and depending on the circumstances, only certified assessors can conduct capacity assessment for some things like activating a power of attorney or guardianship applications. So in general, while there may be no legal obligation for physicians to conduct non-treatment capacity assessments, they should consider whether it's in their patient's best interest to do so. And if you do have the ability and experience to conduct a non-treatment capacity assessment and you refuse to do so, the person asking you to conduct the assessment could complain to the college.
And I just want to say here that this is something we see a lot, where physicians are frequently asked to comment on patients' capacity retroactively when they haven't assessed it, or the physician feels it's totally outside of their area of expertise. And I think physicians really should know that they shouldn't feel pushed to do this because it represents elevated risk for them.
Yeah, that's a really important point, Charmin. If a physician feels they don't have the experience or skill to form an opinion on a patient's capacity for non-treatment purposes, they can choose to refer the patient to a specialized physician, for example, a geriatrician or a psychiatrist, or even a certified assessor for further examination. Another option is to provide medical information in a treating physician's report that confirms the type and severity of the patient's diagnosis, while expressly stating that the report does not constitute a formal capacity assessment.
Okay, that is a ton of great information. I'm just looking at the time. We do have to wrap up and head to our Q&A. So I just really want to thank you both for clarifying many issues surrounding both informed consent and capacity assessments. Certainly, I think we realize that inadequate consent discussions, members should know that they are frequent allegations in the medical legal cases that we see at the CMPA. And we do know that better patient-physician communication in this area will lead to reduced risk of medical legal actions, and it'll lead to reduced patient harm, and that's what we want to see. So as physicians who obtain consent on a daily basis and who also perform capacity assessments, we want to urge all of you to think about what we discussed here today to better understand patient safety and your medical legal risks related to these topics. Now, if questions do arise in your daily practice, we urge you to go to our website, as we have a ton of resources there that are focused on the everyday needs of physicians. But of course, if you do have a medical legal challenge that can't be addressed by our information on our website, then know that we are here to assist you. And we strongly encourage you to phone us at the CMPA. If you have any questions, you may even have the opportunity to talk to Charmin. So we would like to give you a chance to ask your questions now, and we're going to move to our Q&A period. So we'd like to welcome our moderator, Elizabeth Boileau. To have your questions answered during the session, please use the Q&A button in the toolbar that's situated at the bottom of your screen to submit your questions to Elizabeth, and she will pose them to our panel. Over to you, Elizabeth.
Yes, thank you. We are receiving a lot of questions.
Awesome.
I'm going to start with a legal question for you, Mandy. So our member is asking, if a material risk was not disclosed to a patient, will I be liable for any injury that the patient alleges resulted from the treatment I provided?
Not necessarily is the answer. In any civil action that alleges lack of informed consent, the patient must still prove three separate tests. The first one being they would not have undergone the procedure had they been adequately informed of the risks. That's known as the subjective test. The second test is whether a reasonable person in the patient's circumstances would have declined the treatment if provided with full disclosure of the necessary information. That is known as the modified objective test. And thirdly, the patient would have to demonstrate that, but for the treatment rendered, the injury would not have occurred. And that's called the but-for test. So the
Well, I'm
answer
glad I
is
asked
that it
you.
depends. It depends whether the patient plaintiff can also prove that those three tests were satisfied.
Thank you for that. So to something less legal, more in my league, I will turn to Charmin. My patient's husband insists on attending all appointments with the patient. The patient defers to her husband to provide consent on her behalf. Can I proceed based on the husband's consent?
Well, this is a short answer, no. So if a patient is capable, we have to obtain consent from that patient. And patients must always be free to consent or refuse. And their consent should be free of coercion. So consent obtained under any form of a suggestion of compulsion or coercion by the actions, it can be the actions or the words of someone else, the consent is actually invalid. So in this situation, the physician would want to have a sensitive discussion with the patient, telling them that they really need to know how they feel about the procedure or investigation, and they could try and get them in a room on their own without the husband, and emphasize the importance that they are really comfortable with their decision and it's really coming from them. And if the physician isn't able to obtain that, then they will need to inform the patient that they can't provide the care because they don't really have appropriate consent. And again, this is one of those situations where you can contact the association and we can sort of troubleshoot what the options are and approaches to be considered. Mm-hmm.
Thank you for that. I'm going to turn to Lisa. We really are getting a lot of questions. We thank you for your participation and your interest in this topic. So Lisa, what happens when several substitute decision makers at the same level of the hierarchy disagree?
They disagree, is that what you said?
If they disagree, yes.
So I think we touched on this a little bit, but I mean, as a first step, ideally, physicians should try to meet with the substitute decision makers to explore their concerns and their disagreements and answer their questions, maybe discuss what they thought the patient's wishes are or were, if those are known, and what would be in the best interest of the patient. So a conversation would be best, maybe the substitute decision maker can then reflect on that conversation, and maybe if you're lucky, they would come to a consensus. But I mean, if no consensus is reached, sometimes an application to the court may be necessary. And this is a good example of a time to call the CMPA if this, if this particular challenging situation arises. That would be a good example.
That is always a good tip. Okay, back to you, Charmin.
Mhm.
If the consent discussion is most important, why does my hospital require patients to sign a consent form for any surgical or diagnostic procedure?
Mm-hmm. Well, although it's not really a legal requirement, except in Quebec, many hospitals do require that consent forms are signed. And likely this is because it provides further documentary evidence that a consent discussion occurred. In Quebec, signed consent is legally required for things like anesthesia or surgery or not elective procedure, non-medically required treatments. If you're having a body part removed or altered, or you're participating in any kind of research that could interfere with personal integrity, then a consent is required by hospitals. While executed consent forms are not determinative of the consent issue in a legal proceeding, it does have the advantage of providing some evidence that the patient acknowledged that a discussion took place and that some form of consent was given. And that's from a hospital perspective. But again, I really want to encourage physicians to think about their own personal requirements, college requirements in terms of consent. And that really is that whole PAR-Q discussion of paying special attention to capturing the content of that discussion in the medical record. Yeah, so that's pretty much it.
Thank you for that. I'm going to turn to Mandy again now. Do I need consent from a patient or a substitute decision maker to withdraw medical treatment?
Geez, this is a tricky question. So I mentioned earlier on that the courts have long recognized the rights of patients to refuse medical treatment or demand that treatment be withdrawn or withheld after it has been commenced. And that right exists regardless of whether the withdrawal or the refusal of treatment could result in death. On the flip side, when it comes to physicians withdrawing medical treatment, the law is less clear. And where with a patient or their substitute, where the physician feels the treatment has become futile and believes that the treatment should be withdrawn. There is a 2013 Supreme Court of Canada decision in the case of Cuthbertson and Razzouli that did clarify some aspects of end-of-life care. However, the decision is specific to Ontario. And in that case, the court said that under Ontario's consent and capacity legislation, physicians must obtain consent from the patient or their substitute decision maker before life support can be withdrawn. However, because the decision was based on the interpretation of Ontario-specific legislation, it doesn't necessarily apply outside of Ontario.
Mm-hmm. And if I could add something too, Elizabeth, when there is conflict in respect of these complex decisions, we're back to the same thing of trying to reach some form of consensus with either the patient or their substitute decision maker about the goals of continued treatment and what is likely to be achieved. So most hospitals or health authorities will have some relevant policies or even resources to help guide this process. So I encourage physicians to look into that. So that may be involving consulting a hospital ethicist or ensuring that hospital legal counsel or risk management is involved. But for physicians particularly, we need to be aware of whether there are any relevant college guidelines regarding end-of-life care expectations. And also, of course, contacting the CMPA for your own medical legal advice. And because sometimes there can be a disagreement between what the hospital believes is appropriate and what the physicians feel is appropriate ethically. And that's a really good time to reach out to the association, and we're happy to help.
Thank you. Okay, I will hand this one over to you, Lisa. So our member asks, I am providing care to a patient with dementia who I feel is incapable of making their own treatment decisions, but I am concerned their substitute decision maker is not acting in the patient's best interest. The family is really pushing for alternative therapies instead of more proven mainstream ones. And I feel like they're making decisions based on what they would want and not what the patient would want. What can I do?
Okay, this is interesting. I've seen a couple cases like this actually. So again, for this one, like a lot of things, communication is key. And it would be very, very helpful to engage in a discussion with the substitute decision maker to try to better understand their thinking. It's quite possible that the substitute decision maker is in fact making decisions based on what they want and maybe not what they think the patient wants. I mean, as an anecdote, I actually had a case like this where it was only through discussion that I learned that the substitute decision maker was in fact making decisions according to his values, which he actually thought was his role. He didn't realize that his role was to make decisions based on what he thought the patient would want. And so without having this discussion, I would not have learned that. So if you're stuck and getting nowhere, it can also be useful to consult maybe another physician to obtain a second opinion, and then they could give their opinion on the proposed treatment and share that opinion with the substitute decision maker. Some people do that. Discussions with ethics boards on an ethicist, for example, might also be useful, to try and attempt to resolve the disagreement. But keep in mind that many ethics boards and ethicists may also be, not prepared to make that final decision, and really they just prefer to facilitate a dialogue. But the bottom line is, if a dispute cannot be resolved, definitely feel free to call the CMPA for some guidance on this, and may need to turn to a consent and capacity board, which are applicable in some jurisdictions.
Thank you. We're getting so many questions. I'm going to try to sneak in 2 more questions. So I'm going to ask you to answer more briefly for the next one, so we have time. So I'm going to throw this question out to the whole panel. We have a question that says, for treatment consents, can this be documented in EMR, or does it have to be on paper, signed by MD and patient with witness? Since COVID, our practice has been documenting only in EMR.
Okay, well, I'll start and maybe Mandy can add to it if that's all right. Yes, it can be documented in the patient chart, absolutely. And I do understand we're working in situations of virtual care. So I think what's really important is less about how it's documented in terms of the where, but if the elements of the consent discussion are there, you know, the procedure and alternatives, the risks and the questions that are asked and answered, you know, I think you're pretty safe. If you're talking about an office-based procedure, you may, if you're working within an institution, you may also want to work with the institution if they require signed consent for a particular procedure, that, you know, you may have to duplicate it, but it's not an either or. Like, I think it really depends on your context, but in your own office, you can document it in the EMR.
Maybe I'll speak to the witness piece. A lot of there's a thought that having a witness sign a consent form that a patient has signed is necessary or a legal requirement. It in fact isn't. I know it is common, but it isn't really necessary. It proves that potentially the patient signed the consent form, but going back to what we were talking about, consent forms, it doesn't prove that consent discussion actually occurred. So the documentation in the record about that discussion is way more persuasive to a court than someone who has witnessed a signed consent form.
Thank you for that. I think that's all we're going to have time for. So I'll just say we are at 50 questions that we have received. I'll hand it back to you, Lisa.
Elizabeth, I was going to ask you that if we got through all the questions, and
No.
it seems like we didn't. So I'll first of all apologize to our members who are on the call if we did not get to your question. You should know, though, that we actually do go through all of the questions that have come through, and we use those questions to form further content in our educational products. So they will not go to waste. And remember, if you do have a specific medical legal question, definitely do call in because we would be happy to assist you. So we hope that you can take away a pearl or two from today's topic and webinar on consent and capacity. And we wish you a great rest of the day. Thanks so much for joining us. Hope to see you again.